So we will start the session, and duration of each paper will be 5 minutes. And change of presenting author is not allowed. And there is marking system on which the papers will be judged, and the award will be for only those persons who are ratified members. आइए ना.
And Hospital, Kolkata, I will be presenting my paper on the role of intralesional triamcinolone asteroid injection in the management of chalazion. There were no conflict of interest or any financial interests. What is a chalazion? Chalazion is caused by inflammation of meibomian glands blocked by retained meibomian secretions. It is benign and self-limiting, often asymptomatic. Patients usually present out of a cosmetic concern. Larger lesions, however, may be unsightly, and it can lead to some complications. Management includes conservative and surgical. At present, triamcinolone is a simple and effective method in the management of chalazion. Not moving. This study was done because, according to previous studies, intralesional triamcinolone is a procedure that requires minimum facilities and time, can be performed in eyes with multiple chalazia and on lesions that are close to the lacrimal punctum. Hence, it needs to be explored further. Our aims and objectives were to determine the effects of intralesional injection of triamcinolone acetonide, to observe the benefits, to observe the safety of this procedure, and if any complications were arising out of it. It was a prospective clinical study conducted at the Ophthalmology Outpatient Department of R.J. Kaur Medical College for a duration of 1.5 years in 120 cases. An inclusion criteria was followed. The exclusion criteria was also adhered to. A protocol-based preoperative examination was carried out. Okay. Under aseptic conditions, paracaine was instilled into the affected eye, and 1 ml vial of triamcinolone was taken, out of which 0.1 to 0.3 ml of triamcinolone was injected into the lesion. Follow-up was done for 3 such visits at 2 weekly intervals. The success of treatment was defined as the resolution or reduction in size of greater than 90%. Failure of treatment was defined as the persistence of the lesion even after 3 injections or beyond 6 weeks of the last injection. The outcome parameters were defined. The main outcome parameter to be noted was the success of treatment. The results were tabulated. 120 cases showed an average age of presentation of around 27.5 years, with the average size of chalazion being 8.52 millimeter. Chalazia was mostly found on the right upper lid, and 27.5% were found to be close to the punctum. 88.3% cases were primary chalazion. 97.5% cases received injection via the transcutaneous route. 51.7% cases received 2 doses of the injection. Between 2 to 4 weeks, 29.2% cases showed complete resolution and 55.8% cases showed a reduction in size. At 6 weeks, it was seen that 76.7% cases had showed resolution. Complications were mostly not noted between 4 weeks or 6 weeks. About 5% of the cases were taken up for INC after 6 weeks. According to the Wilcoxon signed rank test, there was a significant temporal reduction in the size of chalazion following triamcinolone and acetonide injection at each follow-up. Therefore, at each follow-up, it was noted that the resolution in cases was in a significantly increasing manner between 4 to 6 weeks. There was also a significant need of repeating the dose of triamcinolone between 2 to 6 weeks. Recurrence was, however, not significant. One of the most common complications of depigmentation was observed between 2 to 6 weeks. We can summarize that resolution was maximum between 4 to 6 weeks. 20% of chalazia did not decrease in size by 2 weeks and were given a second dose of triamcinolone. 5% cases that failed to respond were taken up for INC. Significant complication of skin pigmentation was noted only in 5 patients. Response was significantly improved at each follow-up between the 4th and 6th week post the procedure. Recurrence was minimal. Up to 2 doses of triamcinolone was sufficient in most cases. Eye padding was not required. Patients who failed to resolve were taken up for INC. And the most common complication of skin depigmentation was noted, may be due to a higher dose of steroid being used or the subcutaneous deposition of the steroid. We can therefore conclude that intralesional injection of triamcinolone has the advantage of being a simple, fast, and less painful procedure and can be done in children or those refusing surgery, patients with multiple chalasia, in chalasia located close to the punctum. It can be carried out as a daycare procedure and it can be used as an effective alternative intervention for the management of chalasia. Thank you.
Dr. Bose, did you check change in any intraocular pressure?
Yes, during the preoperative examination, before starting the procedure, the IOP was measured and each follow-up also the IOP was recorded.
Any change you noticed in some?
There was no significant rise in the IOP noted in the study.
What is the typical interval when IOP increases after giving intralesional injection?
Generally, it's
Not at just after giving injection, IOP will increase.
Generally, around 3 to 4 weeks after a month post the procedure, there could have been an increase in IOP, but it was not significantly high enough to be documented.
No, it was never beyond 20.
No, it was never beyond significantly high because the dose was very small. Dose was very less, around 0.
Two or three
Yeah.
Do this procedure?
Generally, in those patients, there was either a minimal regression in the size of the lesion, even after 6 weeks following the procedure, or there was a persistence in the lesion, or a recurrence beyond 6 weeks, or in very large chalasia, which showed a like lesser than 50% reduction in size.
Dr. Rupa Gupta,
Thank you.
please.
Good morning, everyone. Today I'm going to present a case report on Fresher syndrome and cryptophthalmus. I have no financial interest. Fresher syndrome or cryptophthalmus syndactyly syndrome is a rare genetic disorder characterized by ocular and multiple systemic malformations at birth. The ocular malformation commonly being reported is cryptophthalmus. It is inherited in an autosomal recessive pattern. The first reported case of FS syndrome was by Jehender et al. And the classification of cryptophthalmus into complete, incomplete and abortive type was done by Francois et al. The incidence of this syndrome is very rare, which is 0.043 per 10,000 live-born infants and 1.1 in 10,000 stillbirths. So I present a case of 2-month-old female baby born to non-consanguineous healthy parents, normal vaginal delivery at term, no perinatal or postnatal complications with one normal sibling. On examination, it was noted on the right side that the eyelashes and the eyebrows were absent. Bilateral temporal hair was growing towards the upper eyelid. There was complete cryptophthalmus on the right side with a missing eyelid and a palpebral fissure, and anomalous extension of the skin from forehead to cheek, completely covering the right side of the eye. The orbital rim was also not well felt, and the lacrimal draining apparatus of the right eye was absent. Whereas on the left side, there was a normal upper and lower eyelids, intact upper and lower punctum with normal orbital cavity and orbital rim. And on further examination, a flat nose with a wide depressed nasal bridge was found, and with partial cutaneous syndactyly found between third and fourth fingers of both hands, associated with umbilical hernia, and the external genitalia were hypoplastic and non-identifiable labia majora with prominent clitoris. So reconstruction surgery was actually planned for this case in a 3-stage approach, like for enucleation of eyeball, creation of fornix and eyelid reconstruction with skin flap, and implantation of prosthesis, but the guardian of the baby refused to operate when explained regarding the risk of surgery and the visual prognosis, as it was a case of complete cryptophthalmus, so the visual prognosis was poor. The findings in our case were compatible with the diagnosis of Fresher syndrome according to the diagnostic criteria proposed by Thomas et al., which consists 2 major and 1 minor criteria, or 1 major and 4 minor criteria. So the major criteria found in our case was cryptophthalmus, cutaneous syndactyly and abnormal genitalia, whereas the minor criteria was found to be congenital malformation of the nose and umbilical hernia. So other studies which were done previously by Thomas et al., Van Helst et al., Slavotinek et al. And Gautuso et al. Also documented that in cases of Fresher syndrome, cryptophthalmus and syndactyly were the 2 major features were found in most of the cases. The consanguinity, which is usually reported in 15 to 24.8% of cases in most of the studies, was not found in our case. The genetic background was like FRESH1 gene, FREM2 gene, and GRIP1 mutations. The age of onset of this disorder is usually antenatal and neonatal, so it can be diagnosed before birth by ultrasound and fetoscopy at 18 weeks of gestation. As the syndrome is very fatal due to respiratory insufficiency, and 1/4 of the cases are stillborn, and another quarter die within the first year of life due to renal agenesis and laryngeal stenosis. So prevention by genetic counseling will be the best approach, as the recurrence rate among siblings being 25%. So these are my references. Thank you. Yes, sir. No, sir. In this case, there was no ultrasonography done. The parents belong to very rural area of our state.
In one slide, you have mentioned like renal drainage system was absent. Just there was fusing of eyelid. So, how you will comment that drainage system was absent? Whether canaliculi.
So it was not grossly visible, so that's why I.
So just you can say
Okay.
it was fused. So only puncta was not seen.
Okay, sir. Okay, sir.
Any more comments?
Thank you, sir.
Thank you.
Ladies and dear colleagues, this is Dr. Shanchari Sarkar presenting before you study of complete blood count parameters in patients with pterygium. We have no financial disclosure to make. As we all know, pterygium is a degenerative disorder of conjunctiva which presents as a triangular fleshy fibrovascular proliferation from the bulbar conjunctiva onto the cornea, located mostly on the nasal side. In India, the prevalence ranges around 9.5% to 13% and is most commonly seen in the rural areas of the country. Regarding the pathogenesis, it is mainly associated with UV light exposure. However, it remains quite controversial. Therefore, role of other factors are also being studied. Elevated levels of nitric oxide and reduced levels of superoxide dismutase and catalase have been found in the tissue of primary pterygium, which suggests the involvement of oxidative stress in this pathology. Elevated red cell distribution width levels may be related with increased oxidative stress in the presence of pterygium. In our study, we wanted to explore the role of oxidative stress behind the pathogenesis of pterygium by trying to study the level of various complete blood count parameters signifying level of oxidative stress in patients diagnosed with pterygium. It was a cross-sectional cohort hospital-based single-center study conducted in the ophthalmology OPD of a rural tertiary care hospital for a duration of 1 year with a sample size of 88 patients, where 44 patients with primary pterygium served as a study group and other 44 patients as a control group. We followed a simple protocol where all the patients were first subjected to routine ophthalmologic examination comprising mainly visual acuity and slit lamp examination, followed by evaluation of complete blood count, where we got all these parameters like the red cell distribution width level, RBC count, WBC count, platelet count, neutrophil lymphocyte ratio, platelet lymphocyte ratio, and mean platelet volume. Following that, we went for the data analysis. Here we can see the mean age and sex ratio in both the groups, which appears to be comparable in all the cases, and also we can see the distribution of the patients according to the length of the pterygium, where we can see 16 patients belong to the each grade 1 and 2, and 12 patients belong to group grade 3, where the pterygium had already crossed the pupillary margin. Here we can see the various values of the various blood CBC parameters in both the groups, and also their statistical significance, the difference. And here we can see only one of the parameters, that is a red cell distribution width, which is statistically significantly increased in the study group compared to the control group. While all the other parameters, there the difference do not show any statistical significance. The same data we have shown here graphically. So to sum up, the red cell distribution width levels, that is the RDW values, were significantly higher in the test group compared to the control group, as denoted by the significant p-value here, while the RDW levels did not correlate with the length of the pterygium. And other indices like the RBC count, WBC count, platelet count, neutrophil lymphocyte ratio, and the mean platelet volume were comparable in both the groups. Although there are many publications showing the influence of UV radiation, the role of the antioxidant system is still subject to discussion. In a previous study, and there has been only one study regarding this by Kotal B. et al., they noted that red cell distribution width level was significantly higher in patients with pterygium compared to controls. In our study also, RDW values were significantly higher in the test group, and RDW values did not correlate with the length of the pterygium, and the other indices, like we have already discussed, were not significant also. So we may conclude that higher RDW levels in pterygium emphasizes the role of increased oxidative stress in disease pathogenesis. Further research in this area may guide us to develop newer treatment strategies in future. Our study has certain limitations, the most important one being not considering the levels of other inflammatory cytokines like CRP. These are my references. Thank you.
Dr. Sanchari,
Yes, sir.
what is the mechanism of basically you have described increased level of nitric oxide and decreased level of superoxide dismutase? How it affects the growth of pterygium?
Basically, sir, there has been, since the pathogenesis of pterygium is not fully elucidated, the various apart from the UV light exposure, various other factors being studied, and one of them is the role of increased oxidative stress and inflammatory cytokines behind the pathogenesis of pterygium. And for that only, we are trying to, various studies previously has tried to measure the different oxidative stress markers. And among that only the superoxide dismutase and catalysts, they have been studied, and in many cases in primary pterygium the levels of these markers have been found to be elevated. And following that only we tried to measure another oxidative stress marker if we can also find that marker to be elevated in cases of pterygium.
Whether other factors were taken into consideration or not, amount of UV exposure, profession.
No, in this study we have not taken into account other factors. That one of the limitations of our study. We have only measured the CBC, and we have compared the different parameters between the two groups, but we have not taken into account any other factors which might also affect the pathogenesis.
Okay, thank you.
Thank you, sir.
So next presenter, Dr. Neha Silpi. Is she here? No, probably. Okay. So after that, Dr. Bharat Gurani.
Morning one and all. I'll be presenting my paper on retrospective multifactorial analysis of pediatric infectious and non-infectious keratitis from a tertiary eye care hospital. We have no financial disclosures to make. Coming to the introduction, microbial keratitis is a serious cause of ocular morbidity in India, second only to cataract. Ocular trauma is one of the major causes of infectious keratitis across the globe. In pediatric population, it can cause irreversible ocular sequelae like visual deprivation and amblyopia. And there are existing challenges in pediatric keratitis like poor communication, difficulty in examination and sample collection. The purpose of our study was to analyze the demographics, the risk factors, my clinical and microbiological profile, and visual and treatment outcome of pediatric infectious and non-infectious keratitis patients. It was a retrospective study done during the period of Jan 2018 to June 2020. 299 pediatric keratitis subjects were recruited from Cornea Clinic of the Tertiary Eye Care Center from South India. The inclusion criteria was clinically infectious, non-infectious keratitis cases from 0 to 18 years of age. The exclusion were incomplete record. Parameter analyzed were demographics, risk factor, microbial culture result, clinical profile, visual and treatment outcome. Microbiological evaluation included scraping in the form of smear and cultures, and the treatment was antifungal, antibacterials, antiviral, steroids or anti-PKM drugs was started based on the etiology. The mean age group of our patient population was 10.61 years. The male to female ratio was nearly 1:1. There was more of a right eye involvement compared to the left, and there was a presentation lag of 0 to 5 days in 162 subjects. Coming to the age group, there were more than 227 subjects were more than 8 years of age, and which formed the majority chunk. The most common risk factor, there were no risk factors in 195 patients. Trauma was present in 81. Contact lens history was there in 3 patients. 1 had a VKC, 3 had exposure keratopathy. There was history of surgical intervention in 4 patients. Systemic comorbidity in 3 patients. 8 had miscellaneous involvement, and exposure keratopathy along with surgery was present in 1 patient. The most common clinical presentation was subepithelial keratitis in 124 subjects, followed by stromal keratitis in 109, followed by epithelial defect in 68. Disciform keratitis was seen in 26, 7 had conjunctivitis and 4 had a melt. 1 patient each had an impending perforation, and 2 had a sclerocorneal involvement. Most common trauma was in the form of stick injury, followed by dust and followed by fingernail trauma. There were around 16 patients who were culture positive and 283 were culture negative. In the smear analysis, polymorphonuclear neutrophils were present in 41 patients. 26 had a fungal filament, 8 showed microsporidium, 2 had acanthamoeba. Gram-positive cocci and pair were present in 2 patients, and 222 smears were negative. The most common species identified was fusarium, followed by acanthamoeba, followed by pythium. Coming to the diagnosis, in the infective keratitis group, the most common diagnosis was viral keratitis, followed by bacterial keratitis. In the non-infective group, the most common was marginal keratitis, followed by keratoconjunctivitis. In the treatment, 289 subjects were treated medically. 6 required glue plus bandage contact lens. 1 required a therapeutic keratoplasty. 1 needed a patch graft. 1 required a AMG. Steroids were started in 35 patients, and steroid and antivirals were given in 121, and antipythium drug were given in 2. Coming to the anatomical outcome, 168 patient had a corneal scar, 2 had corneal thinning, and there were few subjects which were lost to follow-up. The mean preoperative visual acuity was 0.31 and the postoperative visual acuity was 0.22, which was not significant. Coming to the time of resolution, around 100 subjects resolved within 2 weeks, and majority subjects healed within 3 to 6 months, which had a corneal scar later on. So coming to the discussion, there are existing challenges in pediatric keratitis like significant cause of blindness in underdeveloped and developed countries. It needs high clinical acumen for distinguishing infective from non-infective cases. Incidence and prevalence may vary due to epidemiological distribution. There is difficulty in examination of these patients, poor compliance and follow-up, poor socioeconomic strata, and amblyopia and visual disability are other barriers. So we need meticulous clinical and laboratory evaluation in these subjects. Early diagnosis and targeted antimicrobial therapy is warranted. Children need careful and regular monitoring to prevent trauma-induced keratitis. Parents have a huge role to play in reduce this backlog. Counseling should be stressed, and a multidisciplinary interdepartmental approach is needed. So strength of our study, one of the largest sample size, analysis of both infective and non-infective cases. Limitations were retrospective design, and we couldn't perform antimicrobial susceptibility. So majority cases were infective keratitis. Viral was the most common, followed by bacterial and fungal. Marginal keratitis was the most important non-infective case, and the majority patient healed with medical treatment. Only non-resolving cases required a therapeutic keratoplasty. This is largest and probably the first analysis of both pediatric infective and non-infective keratitis from a major tertiary eye care center. Etiology may vary depending on geographical locations. Early and prompt diagnosis and meticulous management needed in these cases. Trauma is the most common cause, and subepithelial keratitis is the most common presentation. Majority patient heal with medical treatment. Recently, pythium is in upsurf, so targeted therapy is needed in these cases. Thank you, one and all.
Just a question.
Yes.
In your series, obviously, the viral keratitis is the most common presentation amongst the infective causes.
Yes, ma'am.
And you were correlating it to the trauma.
Yes,
So
ma'am.
is there any correlation which you thought of as an etiological thing as related to trauma, or was it just an activation of, were these children non-immunized and it was basically the activation of their herpes occurring as a manifestation of the chickenpox in the past probably, or they were non-immunized or never had chickenpox? Did you try to correlate it with that by taking their histories?
We didn't go to that much depth of analyzing the direct correlation between trauma and, because initially majority patients had a history of trauma, but when seeing clinically, because most of them correlate the ulcer with the trauma, the patients, but when seeing clinically we had to distinguish like whether it's infective or non-infective. So, and some patients gave a history of fever also. So there was a slight discrepancy in the history along with the clinical finding, but I don't think trauma directly correlated with
No,
viral.
I'm not saying. Did you take the history, maximum diagnosis was viral keratitis. So did you think over and did you take the history of chickenpox or any vaccinations in the past? Because usually these are
We took the perinatal.
Obviously, what would be most commonly herpes simplex.
Yes, ma'am. Yes, ma'am.
Or maybe herpes zoster as well, both of the entities. So did you go back and try to ask for the history of chickenpox in all those pediatric patients?
We took the perinatal history along with the patient's, mainly the fever history and any other recurrent episodes. That was the main lead to our cases.
Because
Yeah.
if you still have this data,
True, ma'am.
like if it was you could have done that. You could have done
True,
because that it would have given us a cue whether it was mainly herpes simplex or it was a herpetic zoster
Thank you, ma'am.
keratitis, which was being reactivated as a result of trauma. Because trauma is usually known
True.
to activate herpes zoster, not simplex.
Okay, ma'am. Thank
So
you,
that
ma'am.
could have been correlated, or one of the correlations which you could have done.
Thank you, ma'am, for this point. We didn't analyze that way, but
Pediatric age group reactivation is very rare.
No,
Mostly
there are lots of
Yeah,
cases
yeah,
which
but-
have been known of reactivation of herpes zoster occurring
Oh,
in
yeah.
pediatric group also.
Mostly immunocompromised patient there.
Yeah,
in
agreed,
older
agreed.
age.
So trauma is sort of a factor which is actually causing some immunodeficiency at that point when the trauma happens.
true. Slightly immune compromised kind of a patient, because once the trauma occurs, the child may not eat well and there is a malnourishment kind of a
That
stuff.
also, and probably I don't know what is the type of people which are coming to your center.
Most of the rural
What is the socioeconomic status of
semi-urban and rural, mostly rural. Yes, ma'am.
Economic criteria, did you consider what socio-economic criteria?
Sir, because the large chunk of patients which we are seeing are coming from rural background. So,
Maybe social, but in economic reason.
no, sir, we didn't directly correlate with the economic.
Tertiary center is usually in the urban area.
Sir, this was done at Arvind Pondicherry, so that was located in the rural outskirts of Pondicherry. So, majority we were seeing nearby patients only, which are coming from rural area.
Good election.
Thank you, sir. Thank you, ma'am.
Good morning, everyone. I'm Dr. Ruchi, and I'm here to give my presentation on construction site eye injury, clinical profile of patients treated. I have no financial relationships to declare.
Just hold on, we can't see it there.
Oh, sorry.
Yeah, yes, go ahead.
I have no financial relationships to declare. Eye injuries at workplace are major cause of morbidity, socioeconomic damage, disability, despite well-publicized standard for industrial eye protection. Our aim was to investigate the nature of ocular injury seen at construction site and presenting to our eye department over a period of January 2019 to July 2022. A massive construction project is going on at our college. The worker who sustained injuries present to our OPD and emergency department. 224 construction-related ocular injuries were registered, out of which 140 cases were studied in a retrospective per random pattern. These cases were thoroughly examined and managed accordingly. Age group considered was 24 to 48 years. Mean age was 36.3. Sex ratio male is to female was 100 is to 0. There was only one case of penetrating injury, 118 cases of foreign body, 16 cases of abrasion, 4 cases of blunt injury with hyphema, 1 case of lid injury. All injuries were unilateral in nature, and there was no history of use of protective eye gears at the time of injury. 36 patients had the visual acuity of 6 by 60 to 6 by 24. 103 patients had the visual acuity of 6 by 18 to 6 by 9. 107 patients presented on the day of injury itself. 33 presented later on, while 33 presented when infiltrations developed, central 4 mm. Ocular trauma remains a significant cause of monoocular visual impairment worldwide. In this study, there was 100% patients were male, as the study took place at construction site, where all laborers were male. The age group ranged between 24 to 36 years. As this age group, people are young and active and are great concern as comprised to active working age group who drives the economy of the society. As the construction project was going on continuously, there was uniformity in the distribution of injury throughout the year. All injuries were recorded from the workplace. In the report of Desai et al., workplace injury accounts for 19.6% of the place of injury occurrence, and in similar study in Singapore, work-related injury accounts for 71.4% cases of ocular trauma. As found in the past literature, majority cases were unilateral, but stressing the finding of ocular trauma as leading cause of monoocular blindness. Foreign body cases were dominant, as it is seen that people become careless when it is least chance to get injured, and it was seen that people present in the vicinity of the activities were also affected. Most cases were reported on the same day, hence not much loss of vision was reported. Most common type of injury was foreign body. Most of the people were treated in the OPD. However, penetrating injury was treated in OT. Corneal opacity was seen as most common complication. Injury at workplace also involved insurance issue, so a full record has to be kept for a longer period. In our case, only one case with complete loss of vision asked for full report to get insurance compensation.
So we can conclude most of the accidents can be prevented if proper care is taken. A proper protocol for the use of protective gear at construction sites should always be there and followed. But lack of awareness and carelessness result in such catastrophic incidences. In India, attitude of people towards the use of protective gear is very low. Many of them think that accidents have to happen, it will happen as it is God willingness. These results draw attention to the need of intense advocacies and occupational safety and awareness at workplaces. This is important to forestall the debilitating effect of ocular injury in terms of costs and outcome. Thank you.
Gupta, is not there.
Dr. Deepti?
Dr. Deepti Wahi.
Dr. Shalabh Sinha?
I will request to exclude me from marking. I don't know how this paper wound up in this session.
So you're not a participant?
I mean, Dr. Partha put me in this session. I don't know what he thought.
This is a doc.
This wasn't sent as a.
Oh, okay. Oh, there has been a lot of confusion.
So,
So you're not marking him?
yeah, please don't mark. I mean, so I basically wanted to, just share our recent. ठीक है, इस पे नहीं आ रहा है, हाँ आ गया, ठीक है, आ रहा है, क्या कर रहा है? Okay, so I wanted to share my data of about 100 patients in which we had done ocular surface analysis, and this is the equipment that we were using. It's a SBM ocular surface analyzer, and we are well aware that there are three layers to the tear film: the lipid layer, the aqueous layer, and the mucus layer over the corneal and conjunctival epithelium. And each layer has a function. The lipid layer prevents the tear film evaporation. The aqueous layer contains the water and the nutrients to nourish and protect the cornea. And the mucin layer adheres the tears to the eye. And this is how the machine measures the tear breakup time. It's a non-invasive technique using the Placido rings. And each time the patient blinks and then stops, the machine analyzes when the tear film starts to break. And this is how the lipid layer would look, the rainbow colored layer that is over the cornea. The thickness is also measured by the machine, and it also measures or calculates the loss in the meibomian glands, the upper lid and the lower lid, and this is how it pictures and quantifies whether the meibomian gland is healthy or unhealthy or lost. And the machine also has a software that it gives a treatment guidelines, what needs to be done in which patient, whether it is warm compresses or antibiotic ointments or steroids or tear substitutes, and also the dietary supplement, or even the radio frequency, whether the patient needs or not. So this is what the mammalian gland would look like. The normal is here. Do you have a pointer? Pointer? Anyway. So in the middle you have moderate loss, and here you can see severe loss. So this is what a severe loss would look like. This is what a severe loss of mammalian gland would look like in the machine. And the machine, this is where the calculation is, the red and the yellow and the green. So in our 100 patients, this was the sex ratio, lesser number of females as compared to males. And the age distribution, as you can see here, it is the problems with dry eye are more in the working population and lesser in the age groups where we would expect more dry eye to be there. And in the tear breakup time, we had more patients with early tear breakup time as compared to the normal. Tear films normal would be anywhere between 15 and above. If it is less than 15, then there's a problem with the tear breakup time. As regards the lipid layer, the machine marks from A, B, C, D. 0 is very less number, but A is the least tear lipid layer thickness, then B is little more, C and D is normal. So most of our patients were in A or B. As regards the tear meniscus, the height of the tear meniscus, right and left eye, most of the patients had a good height of the tear meniscus. As regards loss, again, most of our patients did not have much of mammalian gland loss in the upper lid or the lower lid. So what we concluded was that it is the lipid layer which is deficient in majority of the patients. Mammalian gland loss is more seen in the upper lid than in the lower lid, and tear meniscus is good in majority of the patients. And this is slightly different from Western literature, where tear meniscus has been found to be deficient in most patients, and you are well aware that we have all the tear substitutes that we have target the tear film, the aqueous layer of the tear film, and not the lipid layer. And what we found is that the mixed type of dry eye was more common, and as yet we do not have any lipid replenishing drops, which was the cause of the dry eye in majority of our patients. We are only giving aqueous replenishing drops, and MGD disease was very common, which needs both antimicrobial and anti-inflammatory agents, and many of our patients do not benefit by just giving the aqueous replenishing drops. And the one drug that has recently come from Alcon, they say that it is going to replenish the lipid layer, but in practice, we had very few patients who have said that yes, this drop has actually made a difference to their symptoms of dry eye. The ocular surface analysis needs a trained technician. It can't be done by anybody. It takes time. It is not patient friendly because you have to evert the lids, the upper lid and the lower lid. And that is why in my practice what I do is that we are offering this test only if the patient has had symptoms of dry eye for a long duration, or if the patient has been shopping from one doctor to the other with symptoms of dry eye. We don't routinely do it in all patients who come with symptoms of dry eye to our clinic. Thank you.